Hello, this is part 5 in a series of lectures on why is there so little relief from musculoskeletal problems, or put another way, why is musculoskeletal disease remain such a disabling problem in the population. This lecture deals with why is imaging techniques like MRI and X-ray not appropriate for every patient. Um, for us in the field, we get asked by a majority of patients to get imaging studies, and they don't understand why in their particular case we don't want an imaging study. These lectures are educational and not intended to manage individual patients. They are not a substitute for patients seeing healthcare professionals. Among the reasons are patients vary and no brief presentation substitutes for formal training. And we used as an example of this as back pain. A majority of back pain has to do with problems at the waist or below, but that doesn't eliminate tumor infection or fracture. And so you need to be evaluated by a healthcare professional and not try to learn this on the web. Patients coming to our sites commonly request imaging studies. This video hopefully hopes to shed light on why imaging studies are right for some patients and not for others. But rarely, if ever, in joint disease is an imaging study a replacement for a good history and physical, even a cursory one. So again, my name is Mark Brzezinski, and my background has been discussed in previous presentations and also on the webpage. So in this particular case, this is a patient. We're going to look at the head as an example first. So this patient falls. They are completely unconscious. Their pupils are blown. They're decerebrate. And so they're immediately going to go for an MRI. But we still have a history and physical that's directing us for an MRI. We have an unconscious patient who is showing neurologic signs, who has a history of trauma. So there's a reason why we're getting an imaging study. In this particular case, the patient actually happens to have both a subdural as well as acute bleed in the brain, along with blood in the ventricles and some shifting of the brain tissue. Now, this study illustrates the problem of why don't we just image everybody? So this was a study done in the American Journal of Sports Medicine. On the bottom, you can click and go directly to study and assess it for yourself. The purpose of the study was to assess a cohort of asymptomatic, and that's the important point, asymptomatic people to determine the prevalence of hip lesions, and these lesions can generally be considered surgical. The average age of volunteers was 37.8 years, a relatively young age. An MRI of asymptomatic patients revealed abnormalities in 73% of the hips, with labial tears being identified in 69% of the joints. And this goes back to our example of the person with knee pain in a previous study. So they looked at the person's knee who had problems with their hip and ankle, giving them knee pain, and when they did imaging, saw a meniscal tear and operated on the meniscal tear. So you may end up with a procedure you don't need, and it could potentially distract you from looking at the actual diagnosis, what's causing the problem. And that's what this slide says. The situation is somewhat similar to what happened 2 decades ago when patients would walk into their doctors asking for antibiotics for colds. And antibiotics, particularly back then, only worked on bacterial, but most colds are viral infections. And so there are consequences to taking antibiotics when you don't need them, one of which would be developing resistance to the antibiotics. And again, one of the problems of getting inappropriate imaging is that it may result in a procedure that the patient doesn't need, and it may distract from actually finding out what the real problem is. So if you look at this MRI of a patient, we actually see a meniscal tear. Is this the cause? We've got imaging. That's what the patient wanted. Is this the cause of their pain? Who knows? You don't know without the history and physical. We've already demonstrated in a previous patient that when they did a single leg squat, they had no control over their knee, and that was the cause of their knee pain. And so imaging supplements the history and physical, but it's rarely a replacement for it. This is the official recommendations of the American College of Physicians, and I suggest that people actually look at the paper itself, because I'm only giving you part of it. But here's what they said. Low back pain is very common, and many patients with low back pain receive routine spinal imaging, radiographs, CT, MRI, despite evidence-based recommendations from the American College of Physicians and the American Pain Society that call for imaging only for patients who have severe or progressive neurologic defects or signs and symptoms that suggest a serious or specific underlying condition. And again, those could include a fracture, a tumor, or an infection. This is problematic because routine imaging does not seem to improve clinical outcomes and exposes patients to unnecessary harms. And go back and look at this paper and similar studies or the recommendations from the American College of Physicians. So in this patient, an MRI is taken and there's spinal stenosis. But in all likelihood, you're already going to first, spinal stenosis generally doesn't cause pain in the back. I think that's a debatable issue. Usually you see weakness in the lower extremities and some other symptoms. But if with this degree of spinal stenosis, it would be somewhat shocking if you didn't if you couldn't diagnose it based on the physical exam alone. And I ran into this recently where a patient was sent for an MRI. They needed to be sedated twice. And they asked me to look at their MRI, but on physical exam, they had no symptoms of spinal stenosis. And so even though radiographically they had spinal stenosis, clinically they didn't have spinal stenosis. They had no evidence of it. So you're not going to do anything differently. Other than potentially, we talked about in previous lectures, how anterior or posterior tilting of the hip can affect the intensity of spinal stenosis. And I would suggest going back to those lectures for those interested. And, I keep reviewing the fact that you need to rule out other serious causes, which is basically saying you need to see a doctor. Now, there are areas of concern with respect to imaging where we're very limited, and in particular, the area of the pelvis. And people who are generally pretty good know that you need to be concerned about femoral neck fractures, for instance, in runners and walkers, or necrosis of the femoral head, or rupture of the acetabulum. And people who do good exams can sort of pick up suspicious cases. And these fractures can be very subtle, and they, once you've ruled out other causes that can be acute, like pregnancy, bowel ischemia, and a whole list of problems, which we'll cover some of which in the comorbid section, then the patient needs pretty much an emergent MRI. And even if that's negative, you have to consider a bone scan. Because if the femoral neck, for instance, fractures completely through, you can get necrosis of the head and ultimately need to a hip replacement. But these two illustrate problems that are rarely considered. And one of the problems is that there's a significant variability in the femur and the acetabulum, the part of the hip that it sits in. You can have a flat acetabulum. It can be pointed in the wrong direction, But one common problem is shown on the top. Kids are often born with inverted feet. It's technically, or their feet are internally rotated. It's technically called cerebral palsy. Most of them grow out of it, but a significant percentage don't. And if it's not corrected, then you end up with a situation in this, as you have in this top image. So a lot of people routinely try to adjust people's foot position, which is important. Bad foot position can lead to a lot of problems, but in this particular patient group, you really, when you're adjusting foot position, want to know, is the femoral neck normal? Because the red dots show lining up between the femur and the acetabulum, and you can see that they line up appropriately when the foot is out of position. When the foot's put into the correct position, they misalign and you can run into secondary problems. And these are very complex cases. Similarly, the inclination of the femoral neck can vary, and managing these patients, ignoring this is non-trivial. And we currently don't have a easy way of imaging. It's not an area where you want to apply X-rays or CT, spiral CT, because you don't want to radiate the ovaries or the testicles. And there's not a lot of, an MRI is too expensive for routinely screening the population. And we need to look for technologies that can better identify it. I mean, there is an exam called Craig's exam that can give you a rough idea on this, but I haven't seen data on the sensitivity and specificity of it. So these lectures are educational and not intended to manage patients. Again, they are not a substitute for patients seeing healthcare professionals. Among the reasons are patients vary, and no brief presentation substitutes for formal training.